It's almost universal, isn't it? That feeling when your digestive system just acts up.
Yeah.
Maybe it's an ache or just something feels off. And figuring it out, it can feel like you need a medical degree.
Totally.
Yeah.
You just want the basics,
Yeah.
right? Without getting lost in the weeds.
Exactly. So in this deep dive, we're focusing on some common issues up top: esophagus, stomach, small intestine.
Mm-hmm.
We've got some interesting material from a chapter covering these, and our mission is pretty simple. Cut through the jargon, pull out what's important about each one.
Highlight the differences, the potential consequences.
Right. So you, the listener, feel more informed and hopefully less overwhelmed.
Yeah, absolutely. Understanding the basics, the key signals, it really empowers you, helps you know when to pay attention or have better talks with your doctor if you need to.
Okay, let's jump in, starting with GERD, gastroesophageal reflux disease. The material says it's basically backflow, stomach stuff creeping up into the esophagus. What's the core mechanism there?
It really comes down to this muscle, the lower esophageal sphincter. Think of it like a gate between your esophagus and stomach.
Okay.
It opens for food that should shut tight. In GERD, that gate gets weak, or it just relaxes when it shouldn't, letting acid splash back up.
And the esophagus lining isn't built for that acid, right? That's where trouble starts?
Precisely. The stomach lining is tough, acid resistant.
Oh.
The esophagus, not so much. So repeated acid exposure causes irritation, inflammation, even sores, ulcers.
Ouch.
And there's this other thing, metaplasia. It's quite important.
Metaplasia. What's that?
It's like the esophagus tries to adapt. You know, the cells in the lower part actually change, not looking more like stomach lining cells.
Trying to protect itself.
Sort of, yeah. But this changed lining called Barrett's esophagus is precancerous. Those cells have a higher risk of turning into esophageal cancer down the line. Adenocarcinoma, specifically.
Wow, okay. So that persistent heartburn really isn't something to ignore. What are the typical symptoms someone might notice with GERD?
Well, heartburn is the classic one. Right. And how it happens is key. Often after meals, especially fatty ones, or when you lie down or bend over.
Right.
And antacids usually help, which is a clue. But there's also regurgitation, that feeling of stuff coming back up.
Yeah.
Difficulty swallowing, what we call dysphagia can happen too. Even chest pain, a chronic cough, hoarseness, or a sore throat.
So it's broader than just the chest burn. What actually causes that sphincter to malfunction in the first place?
Several things can contribute. The sphincter itself might just not work well. Obesity increases pressure in the abdomen, pushing things up.
Makes sense.
A hiatal hernia, where a part of the stomach pushes through the diaphragm, can mess with the sphincter. Pregnancy does it too with the pressure. And if your stomach empties slowly, stuff sits there longer, more chance for reflux.
And beyond Barrett's esophagus, what other problems can chronic GERD lead to?
Well, the constant inflammation itself is esophagitis. That can cause scarring over time, narrowing the esophagus. That's an esophageal stricture, makes swallowing hard. And, of course, that increased risk of esophageal cancer we mentioned.
And it doesn't just stay in the esophagus, does it? The material mentions other related issues.
No, it can spill over, literally. If stomach contents get inhaled, you could get aspiration pneumonia.
Oh, wow.
Chronic laryngitis, voice box inflammation, and even tooth enamel erosion from the acid.
Yikes. So if GERD is suspected, what tests might a doctor run?
An endoscopy is common. They use a thin tube with a camera to look directly at the esophagus lining for damage.
Okay.
And pH monitoring. Usually a thin tube through the nose into the esophagus measures acid exposure over like 24 hours.
Got it. So for GERD, key things are that heartburn pattern after eating, lying down, relief with antacids, and usually no fever or super sharp pain.
Exactly. Now let's shift to peptic ulcer disease, PUD. This is different actual open sores. Where do these show up?
The info says stomach lining gastric ulcers, or the first bit of the small intestine, the duodenal ulcers. How did these feel?
The main thing is pain in the upper middle abdomen, the epigastric area, often described as burning or gnawing. Nausea, maybe vomiting, bloating too. And if they bleed, you might see dark, tarry stools, melena, or even vomit blood, which is hematemesis.
And what causes these ulcers to form?
Two big players: H. pylori bacteria infection and overuse of NSAIDs, non-steroidal anti-inflammatory drugs like ibuprofen.
Right.
Smoking, heavy alcohol use, and even major stress can also play a role, making them worse or helping them develop.
What are the serious risks if PUD isn't treated?
Well, the ulcer can damage the lining deeply. It can even perforate, burn right through the stomach or intestinal wall. That's an emergency.
Definitely.
Or cause a blockage, gastric outlet obstruction, if swelling or scarring stops food moving out of the stomach. And there's a link especially with H. pylori ulcers, to a higher risk of stomach cancer later on.
And like GERD, there can be knock-on effects.
Yep. Bleeding ulcers can cause iron deficiency anemia. A perforation leads to peritonitis, serious abdominal infection. We'll touch on that later.
Okay.
And sometimes a duodenal ulcer can burrow backwards and inflame the pancreatitis.
So how do doctors pin down a PU diagnosis?
Endoscopy, again, is key. Lets them see the ulcer, take biopsies, and testing for H. pylori is crucial: breath tests, stool tests, or from those biopsies.
What really sets PUD apart symptom-wise, especially from GED, the material mentions the timing with meals.
That's a big one. Duodenal ulcers often feel better right after eating because food buffers the acid, but then the pain comes back hours later, maybe even wakes you up at night.
Interesting.
Gastric ulcers, though, can actually hurt more when you eat. And unlike GED, the pain isn't usually tied to your position.
Gotcha.
Plus, seeing blood in vomit or stool is a major flag for ulcers. And generally, PUD doesn't cause the prominent diarrhea you'd see in gastroenteritis or celiac.
Okay, good distinction. Let's switch to gastroenteritis, the classic stomach bug. What's happening there?
It's inflammation of the stomach and intestinal lining, usually from an infection, viral, bacterial, or parasitic. The defining feature, really, is watery diarrhea.
Yes. And what else comes along for the ride, typically?
Vomiting is super common, abdominal cramps, often a fever. And dehydration is a real risk, especially if it's severe or lasts a while.
We've all been there. Who are the usual infectious culprits?
Viruses like norovirus and rotavirus are very common, very contagious. Bacteria like Salmonella, E. coli, often from food, and parasites, Giardia, for instance.
Usually short-lived, thankfully, but any serious potential issues?
The dehydration and electrolyte imbalances are the main immediate worries. Sometimes, especially with bad infections, it can mess with nutrient absorption for a bit, take time to fully recover.
And the source mentions other potential complications.
Yeah, severe dehydration can actually hurt the kidneys, acute kidney injury. And with some bacterial infections, there's a risk of a body-wide inflammation called sepsis if it gets really bad.
How do doctors figure out what germ's causing it?
Often, they don't need to pinpoint the exact bug if it's mild, but if needed, stool tests can look for bacteria or parasites. Endoscopy isn't typical for simple, acute cases.
So the dead giveaway for gastroenteritis versus the others.
It's that sudden onset, bam! Vomiting and watery diarrhea, often with a fever and signs of dehydration. It's acute, not chronic, like GERD or PUD tend to be. And that fever is a key difference, too.
Right. Now, we mentioned H. pylori with ulcers. Let's look closer at that bug. How does it even survive in the stomach acid? That seems rough.
It's pretty clever, actually. Usually ingest it, contaminated food or water, maybe person to person, once it's in the stomach.
Yeah.
It produces enzymes that neutralize the acid right around it, creating this little safe zone. Lets it burrow into the stomach lining.
Sneaky. Does everyone who gets it have problems?
No, surprisingly. A lot of people carry H. pylori and have zero symptoms. But for others, it causes dyspepsia, that general indigestion, feeling, bloating, nausea, or full-blown ulcer symptoms.
So it can fly under the radar. What are the long-term risks if you do have an active infection?
Chronic gastritis, ongoing stomach lining inflammation, is common. And that, as we said, can lead to peptic ulcers. More seriously, it's a major risk factor for stomach cancer and a type of lymphoma called a multi-lymphoma. The thinking is that years of inflammation trigger changes that raise the cancer risk.
And any other systemic effects?
There's some evidence it can mess with your gut microbiome balance. It's also linked sometimes to iron deficiency anemia and vitamin B12 deficiency.
How does it affect B12?
It might interfere with intrinsic factor production in the stomach that's needed to absorb B12. So damage from H. pylori could lead to less intrinsic factor, less B12 absorption.
Interesting connection. How do doctors test for H. pylori?
Several ways. Endoscopy with biopsy is direct. Barium X-rays might show ulcers. But non-invasive tests are common too. Urea breath tests or stool antigen tests. They detect bacteria without needing a scope.
Okay, so H. pylori, chronic gastritis, potential ulcers, sometimes asymptomatic, different from gastroenteritis, no primary vomiting, diarrhea, and GERD, symptoms less tied to position balls.
Good summary. Okay, let's move to a mechanical problem. Small bowel obstruction, SBO. What's the basic issue?
Just like it sounds, a blockage in the small intestine stops food, gas, waste from moving through, like a traffic jam in your gut. What are the signs?
They can be pretty dramatic. Abdominal pain, often colicky, comes in waves. Significant bloating. Your belly gets really distended.
Right.
Nausea and vomiting are common, and the vomit might be greenish yellow, bilious. And constipation can't pass gas or stool. A doctor might hear high-pitched bowel sounds early on. This one's urgent.
What causes these blockages?
Adhesions, internal scar tissue from previous surgeries, are a really common cause. They can kink the bowel.
Ah.
Hernias, where the intestine pokes through the abdominal wall. Tumors, narrowed areas called strictures, or even a twist in the bowel called a volvulus.
Sounds very serious. What happens if it's not fixed quickly?
Big trouble. The blockage can cut off blood supply to that part of the bowel. That leads to ischemia, lack of oxygen, then necrosis, tissue death.
Oh, no.
And perforation of hole is a huge risk.
Yeah.
That spills bowel contents into the abdomen, causing sepsis, a life-threatening infection.
Any other related problems?
Yeah, bacteria can leak from the damaged bowel into the bloodstream. That's bacterial translocation, major sepsis risk, and severe bloating can push on your lungs, making breathing difficult.
How do you tell SBO apart from the other things we've discussed?
That severe bloating, the wave-like pain, the nausea with bilious vomiting, and crucially, not being able to pass stool or gas, that combo screams SBO.
Okay.
No significant diarrhea like in gastroenteritis or celiac, and it's clearly a mechanical blockage issue, different feel from GERD or PUD pain.
Got it. Let's shift to celiac disease. Seems more recognized now. What's the core issue?
It's an autoimmune reaction to gluten, the protein in wheat, barley, rye. In genetically susceptible people, eating gluten triggers an immune attack on the small intestine lining. Specifically, it flattens or destroys the villi, tiny finger-like things essential for absorbing nutrients. That's called villus atrophy.
So what symptoms result from that, Dan?
Will be really varied. But classic signs include chronic diarrhea, often with fatty stools, steatorrhea, that are pale and floaty. Unexplained weight loss, even if you're eating enough. Bloating, fatigue, and sometimes a specific itchy skin rash called dermatitis herpetiformis.
Affects the skin, too. Interesting. And it's an autoimmune thing triggered by gluten.
Exactly. It happens in people with certain genes. HLA-DQ2 or DQ8 are common ones. The gluten sets off this misguided immune attack on their own gut.
What are the long-term consequences of that malabsorption?
Big ones. Anemia from poor iron absorption, osteoporosis from poor calcium absorption, deficiencies in lots of vitamins and minerals because the damaged villi just can't do their job.
Any other associated health risks?
Yes, unfortunately. There's a slightly increased risk of small bowel lymphoma, a type of cancer. Infertility can be an issue. And even neurological symptoms like problems with balance, ataxia, or nerve damage, neuropathy.
How is celiac diagnosed?
Blood tests are usually the first step, looking for specific antibodies like IgA tissue transglutaminase antibodies. A celiac panel checks several, but the gold standard diagnosis usually requires an endoscopy with biopsies from the small intestine to actually see that villus atrophy.
So what makes celiac stand out from the others?
That chronic diarrhea with fatty stools, weight loss, bloating, clearly linked to eating gluten. It's chronic autoimmune, not sudden like gastroenteritis.
Right.
And the signs of malabsorption, anemia, bone issues, plus usually no fever or primary vomiting, set it apart from GERD, PUD, or gastroenteritis.
Okay, finally, peritonitis. Sounds really serious. What is it?
It is serious. It's inflammation of the peritoneum, that thin lining covering your abdominal organs and the inside of your abdomen, usually a medical emergency.
What are the absolute critical warning signs?
Sudden, severe abdominal pain is key. And a very rigid abdomen, doctors call it guarding. Your muscles just clamp down.
Okay.
Also, fever, rapid heartbeat, nausea, maybe low blood pressure if it's really bad.
What causes this inflammation?
Usually a bacterial infection that gets into the normally sterile peritoneal cavity. Most often from a hole somewhere, a perforated ulcer, ruptured appendix, bowel perforation. Can also happen with peritoneal dialysis or severe abdominal trauma.
And the consequences are dire.
Extremely. It can quickly lead to sepsis, multi-organ failure, even death if not treated fast. And later on, adhesions, scar tissue can form and cause chronic bowel obstructions.
The source mentions other systemic effects too.
Definitely. It triggers a massive body-wide inflammation, SIRS, can lead to lung failure, ARDS, and shock. Sepsis is the big worry here.
How is it diagnosed?
Blood tests show signs of severe infection, like really high white blood cell counts. CT scans are often used to find the source, the perforation, the abscess.
So the crucial differentiator for peritonitis.
That sudden, terrible pain with a rock-hard belly. Plus the fever and signs of sepsis, fast heart rate, low blood pressure. It screams surgical emergency, unlike the others.
Right. The pain is way beyond typical GERD or PU. It's not relieved by food like some ulcers. And while you might feel sick, it's not primarily about vomiting, diarrhea like gastroenteritis. It's about that intense pain and rigidity. Okay. To wrap it up a bit, we've got that comparison table summarizing the main symptoms, triggers, and key differences for each. Hopefully, a useful, quick reference.
Yeah, it really helps lay it out. It's striking how different they are when you look closely.
Mm-hmm. How similar complaints like belly pain can mean such different things based on the whole picture.
Exactly. The pattern, the other clues, they're crucial.
So, closing out, it's clear that while symptoms overlap, understanding the specific patterns, triggers, and distinguishing features is really key to getting a basic handle on these GI issues. We hope this deep dive gave you a good foundation for seeing those differences.
Yeah, knowledge is power. Helps you navigate things better if issues arise.
And this is crucial. Remember, this is just information, not medical advice. If you have persistent or worrying symptoms, please see a healthcare professional.
Absolutely. Don't try to self-diagnose. Get proper medical evaluation. That's the most important thing.
Definitely. So, thinking about how connected everything in the gut is, it makes you wonder, right? Beyond these specific conditions, how much do things like diet, lifestyle, stress, how much do they influence the chance of getting these, or how bad they become?
That's a great point. A lot to consider there, the broader picture.
Something to mull over. Until our next deep dive, stay well.